Welcome everyone to the session on electronic Apex locators and their applications in determining the working length in the root canal system. For starters, the very terminology Apex locators is a misnomer. They are to be called and addressed as electronic root canal length measuring instruments to be appropriate. This webinar shall discuss the science behind the working of an Apex locator in detail so that we understand what exactly we are doing with this instrument in the clinical setup. We will understand how to set up your Apex locator, the parts in an Apex locator, how to choose the right Apex locator for the kind of clinical setup that you have. We will also understand the do's and don'ts while working with the Apex locator, and finally, application of the Apex locator that you have chosen in different clinical situations that you will encounter in daily dental practice. We will also pay attention to the contraindications of the Apex locator in our clinic. So, let us begin. A very good morning, everyone. So we have begun with our session on electronic Apex locators. As I've already mentioned that it's a misnomer to call it an Apex locator. The actual terminology should be electronic root canal length measuring instruments or electronic canal length measuring devices. What is the rationale for working length determination? The removal of pulp tissues, necrotic material, and microorganisms from the root canal is essential for endodontic success. This can only be achieved if the length of the tooth and the root canal is determined with accuracy. We all know that root canal treatment procedures should be confined within the root canal system. Maximizing the outcome of root canal treatment is closely related to limiting all the instruments, the antimicrobial agents, and the filling materials to the confines of root canal system at the apical constriction. So that explains the importance of knowing your root canal working length well. A session on electronic Apex locators wouldn't be complete without giving due credit to the person who initiated, who thought about it years ago in the year 1918, Dr. Levitt Ellsworth Custer. The stone shows the 3 generations of Apex locators that were in vogue at that time. In his words, the electrical method is based upon the difference in the electrical conductivity of a dry pulp canal or the one filled with a non-conducting liquid, and the conductivity of the tissues just beyond the apical foramen. That is, the pulp canal and the contents being either a non-conductor or a poor conductor will contrast very sharply with the normal conductivity of the tissues surrounding the apex of the root, so that under proper electrical arrangement, we can detect the instant a broach, for instance, passes through the apical foramen even much more quickly and accurately than can be told by the patient. These were his thoughts and observation way back in 1918. Sonara demonstrated this with a simple DC ohmmeter for measuring the length of a root canal using the direct current. He showed that if an endodontic instrument that is connected to an ohmmeter is introduced into the canal and advanced until the ohmmeter shows a value of 40 milliamperes, the tip of the instrument has reached the periodontal ligament at the apical foramen. Friends, this is the basis for most of the electronic Apex locators being used today. Custer's ideas and principles were revisited by Suzuki in 1942. He registered consistent values in electrical resistance between an instrument in a root canal and an electrode on the oral mucous membrane. History is important because we understand the science behind the instrument that is in your hand today. Hence, we have to pay attention to their observation, their principles and concepts. Now, coming to Sonada, he took these principles and constructed a simple device that used direct current to measure the canal length. It worked on the principle that electrical resistance of mucous membrane and the periodontium registered 6 kilo ohms in any part of the periodontium, regardless of the person's age or the shape or type of teeth. Now, that's a very important observation. And hence came the first electronic Apex Locator, which was developed in 1969, and it was called the root canal meter. So that was the history behind the instrument that we're using today. Electronic Apex Locators, if you read or listened to history carefully, realize that it functions on a very basic fact that we are using the human body to complete an electrical circuit. Now, electrical circuit is something which we don't deal with in a human body every day. So a little bit about the basics of electrical circuit, which we all have done previously. It's just a quick recollection. A basic electrical circuit is a path where an electric current travels on a simple current circuit, and there are just three basic components. You need a source of voltage, you need a path, and you need a resistor. Now, unless these components are there, the functioning of an electric circuit is not possible. So remember that it is the same electrical circuit that functions even in your Apex Locator. Some terminologies, if you understand, you will understand the science behind your Apex Locator. And if you understand this, you will understand why your Apex Locator is not working, or what are the mistakes that we might be possibly ignoring while using the instrument and getting erratic values. So let us have a quick look at it. Voltage. Voltage is basically what gives a push to the electrons to run in a specific circuit, which it has created by creating a potential difference between 2 points. So that is what exists even in the Apex Locator. We'll come to that. So this is how a voltage can be explained, where it pushes the electrons around a circuit, and without a voltage, the electrons would have moved randomly in any direction. And this is what happens when we suddenly touch your Apex Locator while it's in function, with any of the factors which we will discuss later. What is resistance? Resistance is another important terminology which you will frequently encounter while using electronic Apex Locators. The diagram is self-explanatory. Voltage pushes or gives the necessary push for the current to flow, and resistance is a measure of the opposition to the current flow in the electrical circuit. So basically, it puts a control over the flow. If the voltage is high, the current would also be very strong and the patient would experience pain. So we need to have a channelization or a kind of control over the flow, and hence the resistance. Impedance. Now, what is the difference between impedance and resistance? Resistance is basically applied in direct current, and impedance is applicable in your alternating current. Alternating current fluctuates and shows a specific sine wave, which we are all aware of. So electrical impedance is a measure of the opposition that a circuit presents to a current when the voltage is applied. Capacitance. This is another terminology which you'll frequently encounter when you come across the more recent generations of Apex Locators. Basically, it is nothing but reserve energy, reserve electrical energy which is stored. So there is some kind of potential reserve energy which is, in certain areas, which you will also observe in your root canals. So putting all these things together and understanding the basics of electrical circuit, the basic assumption with all the electronic length measuring devices is that human tissue have certain characteristics that can be modeled by a combination of these electrical components. Therefore, by measuring the electrical properties of the model, such as resistance, impedance, it could be possible to detect the canal terminus. So the root canal system, if you have a closer look and pay attention to the components and the constituents of the tooth, it is surrounded by dentine and cementum. And these are obviously insulators to the flow of electrical current. What about the bone? The bone is also an insulator. So what are the conductors? The conductors would be, at the minor apical foramen, we have a small hole in which there are conductive materials in which the canal space, within the canal space, you will see the tissue fluids. They are electrically connected to the periodontal ligament which lies at the apical foramen. and that is an excellent conductor of electrical current. Thus, the dentine, along with the tissue and the fluid inside the canal, acts like a resistor. Now, you know what is a resistor because you know what is resistance, and the value of which depends on the dimension. So, the cross-sectional area of the root canal will determine the effective resistivity that they are offering, as well as the mineral composition of the tooth structure in that area. So you see, so many factors are involved when you are determining the working length using the Apex Locator. Various electronic methods have been developed that use a variety of other principles to detect the canal terminus. The simplest devices use resistance, and of course, the more recent generations use impedance. They use either high frequency, sometimes they are based on ratio method where they are using 2 frequencies, 5 frequencies, multiple frequencies. So when you take an average of all this, you always come closer to a more accurate value. That is how it works, and that is how the recent generations are much more accurate. Now, in addition, some systems are using low frequency oscillations or a voltage gradient method to detect the canal terminus. So to sum it all up, the basic principle, the fundamental principle that resistance-based devices should be able to detect the periodontal tissue at the apical foramen. Okay? So what happens is when the file which has been attached to the Apex Locator, which is a good conductor, comes in contact with the periodontal tissue, when it loses contact with the dentinal structure of the tooth, the circuit is complete, and that is how your Apex Locator detects the working length. And hence the terminology. Now, whatever you saw in the basic electrical circuit, let us try and apply in this particular diagram. The file, which is a good conductor of electricity, is attached to the electronic Apex Locator. The lip clip of the electronic Apex Locator is engaged on the lip of the patient, the oral mucous membrane. This is slowly and steadily advanced into the tooth. Now, what is the hard structure of the tooth? It is a dentine and cementum, which is an insulator. The bone again, which is an insulator. Now, as it comes closer, now there is resistance offered by the fluids here and the structure. The amount of resistivity depends upon the cross-sectional area. So there's a formula to calculate that. These algorithms are already fed into your Apex Locator. So we don't have to worry about that. But here it is just to understand how and why this thing works in this particular way. So the moment the file crosses the limits of the tooth structure and suddenly comes in contact with the periodontal ligament, the circuit is complete and you register a working length. Now that we have understood all this, we all know, this is common knowledge, that any conducting wire like a copper wire which conducts electricity is always insulated so that there is no, you don't get a shock. So suppose there is an open space where there is no insulator and you put another conducting element to come in contact with it. What would happen? The flow of electrons would immediately change direction and start flowing through this, isn't it? So now let us apply the same concept in these conditions. When you place the Apex Locator into this root canal and suddenly when it enters a perforation, again the flow of electricity, the flow of electrons would obviously be detected by this perforation, and hence the circuit would get completed. And there would be a sudden jump in value without detecting the periodontal ligament. Same thing in case of a large lateral canal, or for that matter, when there are horizontal fractures or when there's an internal resorption. So this is how your electronic Apex Locators are also useful in detecting all these conditions. Now that we know so much about Apex Locators, let us have a quick look at how they have been classified and how they are provided to you in different forms. The basic classification is on the type of current flow, that is the operating principle, and the second classification is based on the opposition to the current flow, like we discussed, as well as on the number of current frequencies that are involved. A quick look. We have the resistant type of Apex Locators, electronic Apex Locators. You can see that each Apex Locator has some specifications for it to function effectively. And here it requires a dry environment, it is extremely sensitive, it can easily give false readings, etc. Similarly, alternating current can have three types: the resistance type, impedance type, and frequency type. Now, if you observe carefully, the frequency type has two varieties: the subtraction type and the ratio type. The ratio type uses, in the fourth generation, one uses two frequencies, and the fifth generation uses five frequencies. So basically, the ratio remains constant, but the frequency numbers, number of frequencies that are being applied to improve the accuracy of working length has increased. Then you have the impedance type of Apex locators. Now, impedance type of Apex locators again have certain advantages and disadvantages. So, what happens is when the manufacturer provides you with a certain Apex locator, most of them have a combination of the generation as well as of the features that I've mentioned, either the flow, opposition to the flow, or the kind of electricity that is passing through, etc. So, here you have the frequency type. Now, let us have a quick look at the parts of the Apex locator. All right. So let's come back to the videos later. So here you can see the basic parts of the Apex locator. Just a moment. Hello. Hello. Yeah, I couldn't play the video, so I called you. Yeah, so these are the basic parts of an Apex locator. You can see that this is a tabletop Apex locator which has the regular switch, the volume, and the special mode. This is the display screen, and the display screen shows two images, the tooth and the apical region in detail. Now, when you see the apical region in detail, you can notice that there are some measurements 0, 0.5, 1, 1.5, 2, etc. Now, these measurements do not in any way have any units or indicate any kind of distance numerically from the apical foramen. It is just for you to understand the objective distance from the apical foramen. Now, in order to understand the application of your electronic apex locator, you have to definitely know something about the root apex anatomy. So we have to get ourselves acquainted with the terminologies. So the anatomic apex, that is the tip or the end of the root morphologically, that is where the root of the tooth ends. And here what you can see is a stainless steel file which is jutted out from the root canal apical foramen, that is the physiologic apex. Now, all these terminologies are important for you to understand where to terminate the working length. This is the same tooth which you saw in the previous slide. This is the radiographic image of the same, and you can clearly see that the tip or the end of the root is showing the root canal with the file up till the tip. So you can see the difference in the radiographic apex and the anatomic apex, which is why we have to understand the exact location of the apical foramen. A few things, a few terminologies. The apical constriction. The apical constriction of the root canal is that portion of the root canal which has the narrowest diameter. It is also called the minor apical diameter, which is 0.5 to 1 mm short of the apical foramen. It widens apically, you can see, into a funnel shape to the major apical diameter. The cemento-enamel junction is another terminology. Now here, the cemento-enamel junction is actually a histological landmark where the cemental surface terminates at or near the apex of the tooth. Now, this cannot be determined clinically, although it is the ideal place where we have to terminate our preparation. We always stick to the apical constriction as the termination of our root canal preparation. Why do we consider the apical constriction as the ideal place to terminate the working length? That is because it is considered that the point of healing is most optimal at this point, and the wound of the periapical tissues heals quickly because it is the smallest wound. Now, other considerations regarding the apical foramen. You might have noticed that many times the apical foramen deviates from the long axis of the tooth. It may enlarge with the patient's age due to tooth adaptation to functional activity or any kind of pathological changes. The number of foramina also may be anywhere from 1 to 16. Whereas the distance between the apical foramina and the anatomic root apex may range from 0.2 to 3.8 mm. These variations in apical foramen anatomy render it pretty difficult to determine the apical foramen with accuracy. A landmark study on the topography of apical constrictions is something which we have to be aware of, because very rarely we see a traditional single ideal constriction to the apical foramen. We also encounter tapering canals, a tapering constriction, multiple constrictions along the length of the canal, as well as parallel constrictions. Now, if you go by tactile method, you will definitely not find the ideal location of the apical foramen. Same way, you will over prepare a tapering constriction. Same way, this kind of preparation would have been short. Hence, it is prudent, as well as the study also confirms the view that it's impossible with complete certainty to establish the position of an apical canal constriction during root canal therapy, but indicates that a combination of methods might be more successful than reliance on just one. Now, let us have a look at these images. You see, this is the original anatomy. This is an over-preparation and a violation of the apical foramen. And this is an ideal preparation. So this is how we determine our minor constriction. The terminal point of apical preparation, therefore, is now the apical constriction and not the cemento-dentinal junction, which is a histological landmark. Now let us try and see how we apply the electronic apex locator to determine working length in different clinical applications, just to get an idea how to use it. Let us take the situation of an open apex. First of all, we have to know what is an open apex. It is often used to describe an exceptionally wide foramen in which the preparation of an apical stop is difficult, if not impossible, to achieve. Where do you find open apex? Developmental stage of permanent and primary dentition, as a sequel to pulp death following trauma or caries, or as a result of pathological or physiological resorption of primary teeth due to eruption of the permanent successor. It may also arise from iatrogenic over-instrumentation or root resection. Now, how do you define it clinically? Now, there are many studies which have concluded that anything in an ISO range of 40 to 80 and above will become an open apex. But clinically, when you put the file inside, it passes freely through the apical foramen, and there may be radiographic evidence also of an open apex. The working length for open apices using paper points. Now, what happens in such a will not be accurate. You will be short of your actual terminal point. So how to determine working length in such situations? Quite obviously, you will also use the electronic apex locator to determine the working length, and then you will follow it up with radiographic determination of working length. And then there is an additional technique which has been suggested by Rosenberg, the paper point technique, where initially you will place the paper point 0.5 millimeters short of the electronic apex locator indicated length. If the point comes out dry, it is advanced apically by 0.25 millimeter per increment under magnification. Another paper point is used just short of this, and the working length is then the maximum length that a point can be placed into the canal and remains dry. Rosenberg cautioned that the paper point should only remain in brief contact before the capillary action has taken place. So you can see that it is not possible in some situations to rely on any one particular method to determine the apical constriction. Let us take another clinical situation, the determination of working length in elderly patients. Now, what is the difference in elderly patients? There is a tooth microstructure change which happens with age. The mineral content increases and the organic content decreases. These changes influence the mechanical and physical and chemical properties of enamel and dentine. There is a reduction in the width of periodontal ligament. There is continuous deposition of cementum. Now, what happens? Continuous deposition of cementum throughout life increases the distance between the cemento-dentinal junction and the radiographic apex. So if you were to use a radiograph to determine the working length, then you could get erratic results. And hence, in this particular condition, the electronic apex locator would be very useful and accurate in determining the working length. And also considering other factors that patients generally are not very cooperative, they have limited mouth opening, and you cannot repeatedly raise them for an X-ray, but you can easily confirm your working length repeatedly without additional effort. Now, non-vital or vital teeth. It is proved that an electronic apex locator can be used with accuracy both in vital as well as non-vital teeth. Now that we know its applications and the parts of the apex locator, we have to consider a few things which are very important while using an apex locator. While using an apex locator, it is very important that we do not forget to engage the file clip on the metal portion just below the plastic handle and do not extend it onto the cutting part or at the junction of the shaft and the cutting part. Do not forget to use files and roomers with plastic handles. If you were to use a file with a metal handle, then electric leakage would happen when you touch it with fingers, and that would lead to an error in measurement of working length. Suppose you use a file handle which is made up of plastic, and by Mistake if you touch the metal part with the finger, again you will get an error. Make sure that the battery is engaged properly by using the plus and minus signs properly aligned. Never wipe the probe cord with any other type of alcohol except ethanol for disinfection. Now that we know what are the precautions to be taken, we have to ensure a couple of things. Check the battery, make sure that it is more than 50% charged. Check the lip clip, check the file clip, check them together. Check on the patient by touching the lip clip and the file. Now, I have videos which have been made for each of them demonstrating the same. Unfortunately, we are not able to stream the videos. I shall share the link to the videos shortly after my presentation. I would appreciate if you would go through the videos later on. How to use the Apex Locator step by step. The first and foremost requirement in using an Apex Locator would be a proper isolation with rubber dam. Establish patency of the root canal, because very often even the best of locator, the electronic Apex locators which function on the frequency base, that is the ratio method, also end up with errors because of dentinal debris and necrotic tissue. So establish your patency and glide path properly. Keep the pulp chamber relatively dry. The canal can be slightly moist. Advance in the canal with a 10K file in a slow and steady manner. Never rush. Once the file reaches the apical foramen area, set the rubber stopper with a definitive reference point. The markings of an electronic Apex locator does not depict measurement in any unit. Read the manual properly before proceeding with the use of Apex locator. The don'ts in the manual, the prohibitions, the precautions in the manual are as important as the do's, because that will help you in making sure that your instrument serves you longer and stays durable and reliable. Let us have a quick look at what are the possible errors that you can encounter while measuring the working length. Now, generally what happens is once you apply the rubber dam, you think you're sorted and you have complete isolation. But a closer look would show that there are some areas where there is improper inversion of the rubber dam, which could lead to leakage of saliva and hence improper isolation. Therefore, before beginning the process of determining working length, it is important to seal these areas using liquid dam. Errors. The presence of a metallic restoration or a porcelain fused to metal crown. The solution, flare the axis. Cover the file with a plastic insulator. Now, you can snip off a small piece of the plastic tube which comes in your calcium hydroxide dispensing syringes and engage it over your file, which will act as an efficient insulator when you place the file in the canal. Error. Unable to detect the apical foramen. Very often what happens is, to be on the safer side, we tend to use a smaller file because we are scared that we might go beyond the apex and then we might violate the apex. But what happens is that unless you use a file which fits snugly at the apex and has sufficient contact with dentine, the accuracy of your working length is difficult. Also, another thing that you can do when your file is consistently going beyond the apex is to check with a radiograph. Now, what happens is in certain conditions where there are large periapical lesions due to lack of periodontium, you could easily have errors in your measurement. We have already discussed perforations, fractures, resorptions, etc., where there is a sudden bounce in the value and the reading jumps to -1 without showing a 0. Integrated Apex locators. The generation of integrated Apex locators are a boon to any clinician. These Apex locators can be mounted on the endodontic endomotor and it will constantly give you a reading while you work in the root canal. It helps you in restricting your preparation. It helps you in working precisely and accurately and ensuring that there is no passage of debris beyond the apical foramen. What's new in Apex locators? Now, something very promising that is coming up in the field of electronic Apex locators is a fully automated endomotor like Jenny, which will be introduced soon. It is an integrated Apex locator along with a fully automated endomotor. This instrument works on complex algorithms where the endomotor is able to adapt its file movements within milliseconds and is able to adapt to the change in root canal anatomy without effort. And it also guides your chemomechanical preparation. That is, it gives you a signal when it is time to irrigate the canal. It tells you when to dry the canal. So it's beautiful. Along with this, it has an integrated electronic Apex Locator, which continuously gives you precise length measurements in real time. And there are so many pre-programmed modes available. Plus, the operator can add on more pre-programmed modes to suit his or her style of working. So that is something that we have to look forward to in the field of electronic Apex locators. Now, let us consider the factors which influence the functioning of your electronic Apex locator in the root canal. Now, everybody says, yeah, make sure that your pulp chamber is dry and then you will have no problems. We know that the tooth has to be well isolated, then you'll have no problems. But still, you have some kind of errors happening. Now, what happens is that when you have just established the glide path, you cannot dry the canal with a paper point. And yet, sometimes there is a lot of intact vital tissue, sometimes inflammatory exudate, and blood, which can conduct the electric current and cause inaccurate readings. So we have to be careful while conducting these Apex readings. Other conductors that can cause short circuiting are the metallic restorations. As we just spoke about them, you can just place your plastic tube on the file, caries, saliva, and instrument in a second canal. Never place instruments in other canals while you're determining the working length for one canal. A number of laboratory studies, however, have shown that the recent generations of Apex locators do not get so easily affected by the presence of electroconductive fluids in the canals. It depends upon the type of moisture which is present as well as the size of the file in relation to the apical foramen. A few things which you have to take as a precaution is that remember that there are many equipments which interfere through their electromagnetic waves, and they could cause a problem to work in an abnormal manner. It could cause your EL to work in an abnormal manner. So always keep your cell phone, your remote, and other dental equipments away from your EAL when you are taking a working length. Do not let the file to touch the gums because immediately the value will jump to the apex. This is exactly like how I spoke that when there is no insulator and there is another conducting medium, then immediately the current will start flowing through that. If the meter does not move, then moisten the canal gently with EDTA gel or saline or oxidol. In dry canals, it may not move until it has come very close to the apex. Contraindications. Yes, electronic apex locators also have some contraindications. Now, because it has this electromagnetic interference, it has a potential to interfere or inhibit the functioning of cardiac pacemakers. So it's very important for us to ensure that your patient does not have a cardiac pacemaker. There are several studies which have been done on them, and even the cardiac pacemakers also have different types, and there are some which don't get influenced at all. But when you're not sure what the patient has, it is always better to avoid using an electronic apex locator in such conditions. Simple methods to improve efficacy. It has been proven that when you use a file which fits snugly to the dentin walls while recording the working length, you are highly likely to get an accurate working length. In a situation where the readings are short as compared to the radiographs, try to go in with a smaller sized file. The canals loaded with fluids may not give you accurate results, so try to keep the canal as dry as possible. Pre-flaring. Pre-flared canals always give more consistent values of working length with electronic apex locator. The lack of patency, the accumulation of dentin debris and calcifications can affect your accurate working length determination. Post pre-flaring is also the best time for you to determine the working length. So you can keep checking it again and again during the course of your rotary preparation, but begin immediately after pre-flaring. This is another small tip which I came across on a Style Italiano by one of the members, Dr. Mohammed. When you have a very long canal and the entire 25 mm of your file is inserted into the root canal, it is impossible to engage a file clip onto this particular file to determine the working length. One of the simplest things to do would be to engage the file, a new file onto the file clip, and place the file in contact with the metal part of your file, which is inside the canal, to accurately determine the working length. Or, of course, you can use a 31 file to accurately determine the working length. So that brings me to the end of this presentation, and I can conclude that with all those observations, we definitely know that electronic apex locators, especially the newer generation ones, give us the working length with an accuracy of more than 90%. However, considering the clinical conditions that are present, considering the variations in the mineral content, as well as other factors that we discussed, it is always prudent to use a radiograph to understand the root canal morphology, to accurately use your electronic apex locator, to depend upon your tactile sensation and your knowledge and skill to finally sum it up to determine your working length. Thank you very much for your attention, and do have a look at the clinical videos which are a part of the presentation, which shall be shared shortly.
for sharing your knowledge. I would request all the member who are watching right now live on Facebook. I just request them whatever the questions are there, you can ask the ma'am right now. Ma'am is online. Ma'am will answer you right away.
display. When you switch on the Apex Locator, you can see the display. This display will show you two images in this particular piece. The one to the left shows the tooth into which the file would be inserted, and the one to the right is a magnified apical third image into which, as the file progresses, you can clearly observe it on the graphic display. The numbers 2, 1.5, 1.5 and 0 are just an indicator how close it is. When you switch on the Apex Locator, this display will show you the two images adjusted. Once the probe is attached to the Apex Locator, you will see another icon saying that it has been connected. Where do these extensions go? It has two extensions. One, now you can see this, there are two extensions. One is to the lip clip and one to the file clip. Let's insert the lip clip, which is hook shaped and gets easily placed onto the lip. And then you have the file clip attached to the other. Now we are ready to use this Apex Locator. We should also know that the batteries of the Apex Locator are located and specifically marked, and specifications of the Apex Locator is always given by the manufacturer. So that is for our reference. There is no individual technique which is truly satisfactory in determining the endodontic working length. If you see the electronic Apex Locators, which are the latest, the present generation electronic Apex Locators, they are able to determine the working length with greater accuracy of more than 90% in most of the clinical conditions. But at present, a thorough knowledge of apical anatomy, developing one's tactile sense, correct understanding and application of radiographs, as well as a proper application of electronic Apex Locators will help us in working precisely in most of the clinical situations possible. Hence, understanding the science and applications of electronic Apex Locators becomes a necessity to all of us operators. Thank you. There is understanding the science and applications of electronic Apex Locators becomes a necessity to all different kinds. They can be compact or they can be tabletop. The benefit of having a compact Apex locator is the advantage of being easy to carry and ideal for a first-time investor cost-wise. Let us see how to operate an Apex locator. Any inaccuracies in measurement? I connect my probe cord, the lip clip, and the Apex locator can be of different kinds. They can be compact or they can be tabletop. The benefit of having one locator Apex locator ensure that you have a repeatable stop for accurate measurements. Ensure that the metal file does not touch a metal restoration or a crown during the process of working length determination. Attach the file holder to the metal file. Make sure the pulp chamber is dry. The canals can be lubricated, but there should be no exchange of fluid between the canals. Also ensure that there is no flow of saliva from the external surface. And now we are ready to determine the working length.
To thank Dr. Pavana Kamath ma'am and everybody who are there and who see this webinar series from the beginning. From this, I would love to thank you everybody. This success is goes to you people. Without you, it won't be successful. Thank you everybody who are thanking me from last many days. I can't thank you everyone personally, but I'm thanking you all for these lectures, for everything. Thank you, Pavana ma'am, for giving us such a wonderful time. Thank you, everybody. We have tomorrow another webinar. Stay tuned, stay updated, stay home, and stay happy and stay safe. Thank you, everyone. Thank you so much for sparing such a wonderful time with us. Thank you. Have a nice day.